and she'll be speaking on perimetry misinterpretation. Madam is the professor at RIO Calcutta. Madam.
Perimetry misinterpretation. We all know that perimetry or visual field analysis forms a very integral part of diagnosis of glaucoma. But some retinal condition and some neuro-ophthalmological condition also can cause perimetry changes which are similar to glaucoma. So three types of scenarios are there in which a misinterpretation or misdiagnosis can occur. One is there is no pathology but visual field shows some defects, that is due to artifacts. Second is there is pathology but the visual field defect is not due to glaucoma, due to some other pathology. Then third is there is glaucoma but it's not detected in the visual field recording, that is a misdiagnosis because we are missing an early glaucoma. So in artifacts, we are going to have learning cord and meiotic pupil. If its pupil is less than 2.5 millimeter, then also we can have rim artifact which can confuse at glaucoma. And if there is ptosis, that can also cause pseudoscotoma, and lens ring artifact usually occurs if we use thick rim gases instead of thin, and it's not properly centered and it is not close to the eye. The trick here is that there is sharp depression at the peripheral points instead of gradual diminution. You can mark here most of the points and the center are only -3, -4 like that. But whereas in the periphery, sudden drop to the -26, -28 like that. So this gives us an hint that it is a rim artifact because glaucoma will not behave like this. Then there is some pathology producing the visual defect, but it is not glaucoma. Some neuro-ophthalmological condition and some retinal conditions can produce field defects which will mimic glaucoma. Then we have to clearly differentiate these because otherwise we will be in grave trouble. And the common non-glaucomatous conditions that are misdiagnosis as glaucoma are neuro-ophthalmic conditions like ischemic, compressive, hereditary, traumatic optic neuropathy, or some inflammatory diseases and demyelinating disease optic neuritis, and there is benign intracranial hypertension and optic nerve drusen. All these can produce field defects which will be misdiagnosed as glaucoma. And certain retinal conditions like vascular occlusions and advanced retinitis pigmentosa also can produce field defects like glaucoma. The hereditary optic neuropathy, two more common varieties are autosomal dominant and Leber's hereditary optic neuropathy, which can produce, which can mimic glaucoma. But here the typical field defect will be centrocecal because in these conditions the papillomacular bundle is preferentially affected. As a result, the field defect will be centrocecal one. And another important point is that there is reduced visual acuity because in the glaucoma, the typical visual acuity gets diminished only in the late stage. In the early stage of glaucoma, it doesn't affect the central vision. And moreover, pallor of the neuroretinal limb, as talked by Dr. Rita, it also differentiates these conditions. Then, if the field loss is respecting the vertical midline, then it is not consistent with glaucoma because glaucoma, it respects the horizontal midline and it is due to presence of the horizontal raphe, and bitemporal field loss is usually due to lesions which compresses over optic chiasma, and we should be very careful to diagnose these conditions, otherwise the late diagnosis will cause the life of the patient. And always remember that a visual field defect that respects the vertical midline points to a neurological condition. And in this case, the 48 years old male with visual acuity of hand movement in the left eye with presence of RAPD, this case showing sallow cup and pallor in the left eye. In the field right eye is superiotemporal defect which can easily be mistaken as one of the glaucoma defect, but you see the field defect in the left eye, there is diffuse loss which again is not characteristic for glaucoma. So what is not typical in the case is the younger age of the patient and the sallow and cupping and pallor and the field defect which is typically a junctional scotoma. Ipsilateral there is central field loss and contralateral there is supertemporal field loss. So junctional scotoma usually indicates a compressive lesion at the junction of the optic nerve with chiasma. And this 73 years old male with pseudoexfoliation was getting anti-glaucoma medication and he was referred because his field was progressing. His field in the right eye was a superior nasal arcuate defect which can be mistaken for glaucoma, but the left eye field is superior temporal quadrantic defect. Here the field is respecting the vertical midline and this typical quadrantic defect is not like glaucoma. So when you see both the fields together side by side, you can appreciate the pattern and you can see that there is a left homonymous a superior quadrantenopia which suggests a suprachiasmal lesion, and it is not glaucomatous. So always take care when the temporal defect which borders on the vertical midline, because it is not typical for glaucoma. This 65-year-old male with a visual acuity counting finger 1 meter in the right eye with RAPD and color vision deficit with a disc cupping 0.8 and inferior notch. The fields are right eye, its field is quite advanced, and the left eye there is only temporal loss. Again, temporal loss suggests some neurological condition. Here there is gross asymmetry between the field of the both eye in spite of the similar optic disc change. So that should alert us that something other than glaucoma is at the play. And when we neuroimage, we can get a cranial pharyngioma in this case. So always, and another thing is that here the visual loss which is only counting finger 1 meter, and there is gross field loss in the right eye which are not correlating with the disc change. So always we have to correlate the disc appearance with the field change, otherwise the diagnosis of glaucoma should be revised. And this 69-year-old male who is hypertensive noticed painless loss of vision in the inferior field on waking up, and color appeared to him less bright, and the field was both eye inferior altitudinal defect, and altitudinal defect again suggestive of ischemic optic neuropathy. And if we see the disc here, disc is edematous, but once the edema subsides, it is really very difficult to diagnose the ischemic optic neuropathy and glaucoma. But here we have to at least think it as a differential diagnosis before diagnosing it as glaucoma. Then this 53-year-old glaucoma patient on travoprost was having glaucoma. He is a known glaucoma patient, but suddenly he complains of sudden diminution of vision, and you can see that there is in the left eye there is inferior altitudinal defect, which is again suggestive of ischemic optic neuropathy. Here the patient has developed a ischemic optic neuropathy. So patients can have more than one pathology. Once the patient is glaucoma, need not be a glaucoma patient always. And any recent change in the course of the disease is suspicious, because the patient was having sudden loss of vision, and it will be dealt in the history chapter. And here the immediate diagnosis is very important, because usually the arthritic variety is usually due to the giant cell arthritis, which is an ophthalmic emergency. So you should suspect neurological conditions when the scotoma that obeys the vertical midline, because glaucoma always obeys the horizontal midline. A field defect which appears suddenly is unlikely glaucoma, because glaucoma is a chronic process, and purely central scotoma with preservation of the peripheral field again is non-glaucomatous, and rapid deterioration of visual field in spite of a good IOP control suggests some compressive lesion or some other condition which is again not glaucomatous. And when the field loss is not correlating with the degree of cupping, you should be very, very careful. And field deficit not consistent with a glaucomatous pattern, because glaucoma always exhibits some pattern like paracentral scotoma or enlargement of the blind spot or nasal defect or arcuate defect. If these are not present, then it is not, the field defect is not due to glaucoma. And always examine both the fields side by side to recognize any pattern, otherwise pattern will be missed. And this is a case of superotemporal BRVO, which is manifesting as an inferonasal field defect. But this condition will become obvious if you dilate the pupil. So dilated fundus examination is very much essential. And another thing is that visual field peripheral constriction occurs in case of pan-retinal photocoagulation. It is an iatrogenic field defect. And this again is obvious when you dilate the pupil. So dilate the pupil before giving any diagnosis. This is a peculiar case, because here the 63-year-old male, perimetry was never done in this case, and with only the findings of the OCT, the patient was diagnosed as glaucoma and getting treatment. When ultimately the perimetry was done, it was showing a bitemporal defect, and bitemporal defect usually indicates some chiasmal region, and on neuroimaging also pituitary tumor was the cause, and that patient was being treated for glaucoma, whereas he was developing some other chiasmal lesion. And never diagnose a case as glaucoma with OCT or GDX alone without perimetry. Then certain misdiagnosis cases are there. One is nasal step. We should not miss an early nasal step. Usually nasal step occurs in association with other arcuate or paracentral scotoma, but it can occur as an isolated glaucomatous defect, because 7% of initial field defects are peripheral nasal step defects. So we have to be careful not to miss this thing, and never assume that glaucomatous damage is only peripheral, because in the earlier it was told that the decreased sensitivity in the peripheral, in the macular region was not glaucoma, because the glaucoma, central vision was affected at a later stage. But nowadays the structural and functional elements, they suggest that it can be affected in the early stages. And if there is even a single central point defect with a 24-2 or 30-2 pattern, always consider adding a 10-2 to your field examination. Here you can see in the field, in the 24-2 field, when inside the star there are only 10 points which are not showing any depression, because these points are 6 degrees apart. But if you do order the 10-2, you can find some points with depressed point, because 10-2 examines the point density is only 2 degrees and you can catch the early defects. And in the to conclude, we can say that never diagnose glaucoma based on visual field defects alone. Interpretation should always follow clinical diagnosis. Only seeing the peripheral visual field, never diagnose glaucoma. Always recognize a red flag and examine more carefully when something is not typical. Always remember that the field defects typical of glaucoma can also be produced by lesions such as AION or retinal vascular occlusion, and you have to be very sure that the defects are glaucoma, otherwise don't start glaucoma treatment. And keeping these things in mind will help to detect glaucoma masquerades and avoid missed and misdiagnosis. Thank you.
Thank you, Dr. Sumita, for excellent talk. There is nothing more to add, nothing more to delete, but only little summary is that if a vertical field or a quadranopic field defects and it is associated with a low vision or vision which is not explainable, it is out of proportion to the visual loss and the changes, then you think of neurological condition. Very straight. Not only diagnose that neurological condition, you can always say that with the repeated field, you can say that the tumor, the brain tumor is stable, it is not increasing, or you can always say that his visual field is deteriorating, that means the disease is occurring even if it is operated upon. So that is one way which one must see that the neurological are completely different. It is a vertical partition altogether. The problem arises with the glaucomatous field defects. Never consider a single field as the treatment modality or treatment parameters. So a field has to be taken positively if the repeated fields are showing the same type of defects. Repeated means 2 to 3 fields in a span of few days, within a month of or so, 2 or 3 reliable fields, then you give some importance to it. No single field or reliable, so-called reliable field is taken for granted for the treatment modalities. You must find out the other causes of the same type of the changes in the retina. So the first and the most important retinal condition is the vascular block, which will produce the same type of visual field defects as in glaucoma. The second condition, which Dr. Sumita said, that the vascular lesion which is seen after the dilatation. The second most important thing which should be excluded is the retinitis pigmentosa or macular degeneration, which comes in the OCT, and you depend very much on OCT and the central field defects like that, and you give a lot of importance to it. No, the field defects should always be analyzed in association with the retinal changes in the form of vascular block, old vascular blocks, macular pathologies, or any disease of choroid or choroidal scar. So that has to be taken into consideration before you really take it as a glaucomatous field defects. Thank you very much, Sumita.